I'd like now to direct you a little bit into inflammatory bowel diseases and a little bit about endoscopy and IBD and how perhaps we can improve reporting that we do. So I'm just trying to get on. So sometimes when we're in clinical practice and a patient comes new to us and brings his endoscopy reports, I think they're sometimes quite short. So these are some examples like disseminated inflammatory changes in the inspected parts of the colon. There are signs of significant inflammatory activity consistent with ulcerative colitis. Ulcerative colitis in remission, but also activity in the rectum, or moderate signs of recurrent Crohn's disease at the site of the anastomosis. And I'm sometimes having a problem in clinical practice because I should base my therapeutic decision on this endoscopy. And sometimes I think, how severe is this inflammation? I'm not sure. So the question is, what should I do now? And sometimes I say, dear patient, we have to repeat the endoscopy because before I make a therapeutic decision, I want to have a clear view and objective parameters to assess it. And then, of course, the patient asks me, why again an endoscopy? I just did one. And I tell them, I'm not doing a better endoscopy, but some signs or description of the inflammation are missing. And if you ask the patient, okay, let's do another endoscopy, I think it's easy for me to say, but if you see the endoscopy or the colonoscopy, they are not one of the favorite diagnostic tools to be applied from a patient's perspective. Now I think a little bit of a pivotal question. Who of you can just think about yourself, uses a standardized scoring system when reporting endoscopic findings in IBD? So probably most of us do not. When we ask ourselves why we're not using it, we have okay scores to describe it, and at least it's an objective parameter, we would say, they're too complicated. But they're not so complicated. If you're interventional endoscopists, you're learning about pit patterns, the Kudo classification, the NICE classification. So I think you should also be able, let's say, to depict and reflect also endoscopic scores. And I'd like to give you a little overview. I'll first start with one of the scores that's too complicated, at least for me, the CDEIS score. So I will not introduce you to it, but rather take the SESCD score. It's a little simplified. I think that's always good, at least for me. And here you can see the 4 features that are there that you assess in the 5 segments: ileum, right colon, transverse colon, left colon, and the rectum. So 5 segments in Crohn's disease, and you can see here the features. And for each segment, you just calculate it. And I often have it besides myself, if I write the endoscopic reports, if I don't remember again what was the score for ulcerations above 2 centimeters, it's 3, as you can see here. So I think if you then really segment for segment, you assess the inflammatory activity and perhaps describe it also in your endoscopic report, I think that's very helpful for subsequent diagnostic and also therapeutic steps. So it's the presence and size of ulcers from 0 to 1 till 5 millimeters, to 2 till 20 millimeters, to 3 above 2 centimeters. The extent of the ulcerated surface, so you can say it's a semi-quantitative measure. There's none, below 10%, below 30%, above 30%. And the extent of the affected surface, and where is an inflammation present, below 50%, 50 to 70%, or over 70%. Then the easiest presence and type of stenosis is it passable, 1 point, multiple passable, 2 points, impassable, 3 points. That's it. You do this for these 5 segments, you calculate the score, and then you have, I think, an objective parameter, especially prior to the initiation of therapy and during therapy, to assess a treatment response. So here's another video. Okay. Another Crohn's disease patients with ileocolitis. You can see here the colon. There's clinical activity, heightened fecal calprotectin levels and SCRP levels. So just think about this segment. Now this is a left colon. Again, from the splenic flexure till the rectum. Okay, we now go to the SCD. So what would you say? Presence and size of ulcers? Yeah. Probably above 2 centimeters, 30% of the surface are ulcerated. Also the affected surface area, 70%. No stenosis. Okay, we come back to a 9. I'm sorry a little bit. The variety of my endoscopic videos do resemble themselves. So this is again a 9. And now after initiating a therapy, so now you can see there is a therapeutic response, but we still see active signs of inflammation. Here we have an ulceration. Here's also one. Here's at least an erosion. You can see reddishness of the mucosa. So it's the same segment. After 10 months, after initiating a therapy, patient is feeling better. There are no steroids. The biochemical parameters have gone down. So if you calculate now the SES-CD score again, I would say, yes, there was an ulcer. I mean, even if there's only one ulcer above 2 centimeters, we have to take it in, even if all the other ulcers have vanished or have gone down. I think that's one of the weaknesses of the endoscopic scores that we use. We always assess the worst lesion, and even if they change in numbers, we still don't, it's not reflected in the score from my point of view. But the extent of the ulcerated surface, I would say, has gone down between 10 and 30%. And also the excess extent of the affected surface by inflammation has gone down. There's no stenosis. So I would say a 6. So at least a good treatment response, a reduction at least by 30%.
Next is, what is the significance? This is a meta-analysis published in an oncological journal where they had 12 studies with about 6,000 patients. About 22% of those, about 1,200, had PIPs, post-inflammatory polyps. And in the meta-analysis, they came out that there is an increased risk of colorectal cancer as compared to those without post-inflammatory polyps.
Well, I think, and that's all, both with virtual as with dye-based endoscopy, your colon needs to be very clean.
Yeah.
That's, I think, the main drawback from all chromoendoscopies. If the patient isn't very clean, well, you're actually seeing less than without chromoendoscopy, or at least that's my experience.
And it's also my experience. Generally, those IBD patients like our bowel prep even less than the other patients. Yeah. So we really have to convince them how important it is. And it is different from just looking whether there's active colitis, right? So they are not so used in doing it that well.